Today we're going to talk about progesterone. Last week I spoke about estrogen, and we will contextualize this in both cycling and perimenopausal, postmenopausal women so that you can understand what is contributing to the symptoms in this transition, as well as how to interpret some of the information coming out about hormone replacement therapy and what would be wiser to take and less wise to take. At least you can be more informed to ask your doctor if you have questions like that. The first thing to understand is to sort of back up to the cycling years. And when a woman is cycling, there is about 60 times more progesterone produced throughout the whole cycle than estrogen. It's significantly more. And this is really basic, but it is critical to understand, because when you look at it this way, the sheer amount of progesterone that should be produced, then looking at optimizing this particular hormone, and it's produced mostly from the ovaries, is driving the metabolic rate in driving fertility and setting up pregnancies so that a woman can carry a baby to term. It's really all dependent upon progesterone. Progesterone is pro-metabolic. It actually drives or accelerates mitochondrial activity, and it works in conjunction with thyroid hormone to increase metabolic rate. So if progesterone levels decrease, you usually also see a decrease in thyroid hormone, at least at the conversion level, and an increase in estrogen, and therefore an increase in symptoms. So if you're just tuning in, it's a good idea to go back and watch the estrogen video to get more context. But in the follicular stage, you have the pulse or the spike of estrogen, which starts to slowly decrease. Then you have ovulation, which then triggers the release or the spike of progesterone that should sustain itself more than estrogen all the way until day 1 of your cycle. Now, if you don't produce enough progesterone during that time period, or because you don't ovulate, or because you're under a lot of stress for all of the reasons we've talked about in the core series, then you will have symptoms that week leading up to day 1. And they're all the typical symptoms. So what happens going into perimenopause is that ovulation becomes sporadic. And as a result of that sporadic nature, you have sporadic pulsing of progesterone. Sometimes it's released, sometimes it's not released. Yet, estrogen more or less stays the same. So you don't have progesterone to mitigate the effects of estrogen. And as a result of this increase, this relative increase of estrogen to progesterone, you get a response of stress hormones. The stress hormones are stepping in temporarily. It's an adaptation response to supply or temporarily increase mitochondrial energy production to make up for what was lost from the progesterone. And that contributes, along with the elevated estrogen, to all of the hot flashes and all of the stuff that you don't like as you transition from this period into menopause. So knowing all of that, if you're going to consider doing some kind of hormone replacement, it doesn't make sense to add estrogen. Almost no woman has too little. And so you might be thinking, well, what about osteoporosis? Well, every fat cell, as I mentioned in the estrogen video, every fat cell contains aromatase, which is an enzyme that converts androgens, it could be DHEA or testosterone, into estradiol. So we never have a tissue level shortage of estrogen production, but we will have a massive decrease of progesterone. Still a little bit is made in the adrenals, but not nearly what was being made post-ovulation. And the reason I bring this up is that generally speaking, menopausal women and men have about the same amount of estrogen. It's a little bit higher because a healthy woman is going to have about 10% more body fat than a healthy man will. So she will have more aromatase, so she will produce more estrogen, but it's not significant. And men don't experience the same osteoporosis that women do in menopause. So obviously it's not because of estrogen. It is almost certainly because of the lack of progesterone. If you were going to consider HRT, bioidentical progesterone is the one that you would want to take. And you may want to pair that with the natural form of thyroid, like natural desiccated thyroid, which is essentially just freeze-dried thyroid from a cow. Both of those things can compensate for the loss of those two hormones, or the decrease in those hormones as menopause arrives. Taking that will significantly dampen all of the symptoms, because that's what should be dampening those symptoms while you're cycling. But this doesn't necessarily address root cause. So if you are cycling and you are experiencing the symptoms of estrogen dominance and high stress, aka low progesterone, low thyroid function, weight gain, mood swings, insomnia, swelling or water retention, all of these things are the effect of estrogen dominance, and you are still cycling, then you have to ask yourself, well, what is preventing my body from making enough progesterone and thyroid to counteract this? And so now we have to look at all of the stressors in the environment, including our psychological stressors. So this is a multi-dimensional approach. I covered all these things in the course series, but it's managing your light inputs so that you're sleeping well. It's eating enough food so that you're not triggering stress hormones. It's eating enough carbohydrates so you're not triggering stress hormones. It is making sure that you're micronutrient replete, you're eating whole foods, that you have low toxin load, so maybe you're adding sauna, that you are doing a lot of NEAT, walking, chores, things like that. All of these things contribute to a lifestyle that is pro-metabolic, or optimizes your metabolic rate. Interestingly, in the Hunza Valley, women are reportedly giving birth into their early 60s. What this basically tells us is that perimenopause doesn't occur for them until 15 to 20 years later than it does for women in the modern world. The only way to explain that is the amount of stress that women are under in the modern world. And so it's just more of this. And as perimenopause begins sooner, it is a sign of sped up aging in an overload of stress hormones. I want to take a moment here to talk about some herbs that are commonly used to address this, why I think some may be useful, some may be harmful. The classic one is Vitex or chaseberry, and this really is only effective during cycling. And essentially what it does is modulate or increase luteinizing hormone and inhibiting follicle stimulating hormone to help upregulate progesterone production. So as you move into perimenopause, it will become less effective, and as you move into menopause, it'll essentially be not effective at all, as the ovaries are not really functioning anymore. Another one that I hear about a lot is ashwagandha and these adaptogenic herbs, and they can be positive and they can be negative, and so it's hard to say unless you actually take them. So if you're willing to experiment, then you're going to find out if it's beneficial or not. The issue with adaptogens in general is that they can adapt the body by overproducing stress hormones from the adrenal glands, which would be overstimulating. It would exacerbate existing problems rather than ameliorate them. So anything that falls into this category, especially if you are experiencing a lot of cortisol, a lot of catecholamine release, a lot of estrogen dominance, it will most likely not have an impact, or it will exacerbate the problem. In the world of bioenergetics, what's most commonly used outside of bioidentical progesterone and natural desiccated thyroid is vitamin E. Vitamin E is a mild aromatase inhibitor. So if aromatase is being driven by elevated cortisol, it can dampen that down a little bit. You want to make sure that if you get one, you're getting a full spectrum vitamin E with all the tocopherols. And I like the Health Natura brand. I use that personally and recommend that to clients. The other tool that you can use is aspirin. And aspirin is also a mild aromatase inhibitor, and it also inhibits the inflammatory producing enzymes COX-1 and 2, COX. And the product of the COX enzymes are the inflammatory markers, prostaglandins, especially PGE2. And so aspirin has the ability to lower inflammation by basically inhibiting those enzymes, as well as lowering aromatase activity. Now, this is still a patch. It doesn't address the underlying issue, but if you have sort of overwhelming symptoms, aspirin and when I say this, I'm not talking about the regular drugstore variety. I'm talking about USP pharmaceutical grade aspirin that has no additives to it. And also Health Natura makes it. And I hear so many positive things from clients that take this. It's a very small amount that you would take. In the combination of these two together has very significant impacts. And it's not only if you are experiencing an imbalance of estrogen to progesterone, but also if you are depleting, you're in a process of a multi-year depletion of linoleic acid. So if you've already corrected that piece by keeping your LA below 5 grams, you still have all the LA historically in your cell membranes that need to turn over. So in that time period, you can take these two substances, which will prevent the conversion of that LA into arachidonic acid, which feeds the COX enzymes, which then produces the inflammatory prostaglandins. So it has a multi-dimensional benefit taking these things. So just to combine all of this together, it's important to recognize that progesterone is the dominant hormone driving not just the woman's cycle, but her metabolic rate during cycling years in combination and supporting thyroid hormone. It's not estrogen. Estrogen continues through perimenopause and menopause. It will get lower, but the ratio between those two things significantly gets higher in favor of estrogen, as progesterone is predominantly produced in the ovaries, with a small amount being produced in the adrenals, which is about equivalent to a man's also. And that is the primary hormone that is supporting bone. It's stimulating or catalyzing osteoblast activity to produce more bone and stronger bones. And it can, by taking these things, you can balance out the symptoms that come along with perimenopause. But this still doesn't negate addressing the underlying imbalance, the overstimulation of the stress hormones and the overproduction of estrogen. And all of that stuff is laid out in the core series.